So I'm going to make sure I always try and bring something new to my talks, and I try not to do the same talk more than once. So Jim, there'll be something new in here. One of my favorite books is by management guru and professor Dr. C.K. Prahlad, who is the author of The Fortune at the Bottom of the Pyramid, in which he writes, and I quote, "If we stop thinking of the poor as victims or as a burden and start recognizing them as resilient and creative entrepreneurs and value-conscious consumers, a whole new world of opportunity will open up. 4 billion poor can be the engine of the next round of global prosperity and trade. What is needed is a better approach to help the poor, an approach that involves partnering with them to innovate and achieve sustainable win-win scenarios where the poor are actively engaged." He writes about a vision of co-creation of a solution to the problem of poverty that can only be unlocked if large and small firms, NGOs, governments, development agencies, and the poor themselves work together with a shared agenda. His bottom line is simple. It is possible to do well by doing good. And it's this mantra that captures the essence of what I'll speak to you about this evening. What I've titled tonight as A Journey in Social Innovation, bringing the Cola Life model from conception to community. It's an exciting time to be working in the field of global health and development. The Millennium Development Goals, 8 targets set in 2000 that have galvanized unprecedented efforts to meet the needs of the world's poorest, are coming to an end in 2015. And this gives the global community an opportunity to reassess our strategies and approaches for the post-2015 agenda. It gives us a chance to analyze what has been working and what hasn't. We're faced with the challenge of developing new models and innovating, while at the same time putting into practice much of what we've learned over the past few decades. While the progress and advances that we're making in other areas of science and technology are progressing at a rate the world has never seen before, the rate of progress in involving people's health and improving basic quality of life simply hasn't kept pace. And this becomes disturbingly clear when we look at the rate of decline in childhood mortality over the past 20 years. Between 1990 and 2010, the overall rate of decline in childhood mortality was less than 2% per year. To have any hope of meeting the MDG of reducing childhood mortality by 2/3 by 2015, we would have had to have gone 5 times faster and seen a rate of decline of around 10% over the last few years and into 2015. Clearly, the status quo hasn't cut it. We're going to need to do things a little differently. Part of my work focuses on identifying or developing, implementing, and then evaluating the types of solutions and models that can help bridge that gap. The internet, mobile technology, social media, and a movement towards open source development continue to enhance our means of accessing information and collaborating across cultures, borders, socioeconomic statuses, and disciplines. The concept of reverse innovation no longer limits or restricts movement of ideas from north to south or from developed to developing. We're finally starting to break down our traditional sectoral silos. Notions of the public sector as being only inefficient and corrupt, and the private sector as being purely profit-driven, are starting to change because we see exceptions. We see examples of us achieving great things, finding win-win solutions, and recognizing what can happen when we bring the best of each sector to the table. These traditional divisions, whether between private or public or otherwise, only hinders innovation and it impedes what is necessary. And finally, we're starting to see that paradigm changing. And today I want to share my story of how we're trying to help change that paradigm. In sub-Saharan Africa, approximately 1 in 8 children will die before their 5th birthday. In Canada, just to give you a comparison, that figure is closer to 1 in 200, a stark comparison. And the worst part is that the majority of the almost 7 million childhood deaths that occur each year are preventable. They are preventable with existing solutions, things that we already know about. Yet, coverage levels for these effective interventions are remarkably low in most developing countries. A recent review of the 42 countries that accounted for 90% of all childhood deaths showed that only 2 out of 9 key interventions reached more than half of all children. Diarrhea, for example, as Jim mentioned, it's the second leading cause of death in children under 5. And yet, it's easily managed with 2 simple medicines, ORS and zinc, oral rehydration salts and zinc. But in many parts of the developing world, access and utilizations of these medicines is still very low. And this is due to a number of factors, not the least of which include long distances to access points. Our research over the last year has found that caregivers from rural communities in which we're working in our intervention districts, they traveled an average of approximately 7 kilometers to get to a health center, which was the only place they could get these medicines in rural Zambia. This was usually by foot. Regular stockouts at health centers. Previous research has demonstrated that on average, 1/3 of the world's population has no effective access to modern-day medicines and vaccines. In sub-Saharan Africa specifically, some 47% simply can't obtain essential medicines when they need them. A lack of knowledge and training by health workers, as well as by caregivers. Our research found that even when zinc was available in rural health centers, which was rare, it usually wasn't prescribed. In fact, at our baseline, before our intervention, we found that less than 1% of caregivers used the globally recommended gold standard treatment for diarrhea, ORS and zinc. When it came to caregivers actually getting ORS and taking it home to prepare it for their sick children, we found that approximately 40% of caregivers who used a 1-liter sachet from the health centers prepared it incorrectly. This is because a 1-liter sachet isn't appropriate for home use. Firstly, many mothers don't have a way of measuring out 1 liter of water effectively. So they use whatever container is on hand, and that often results in a preparation of a solution that is either too diluted or too concentrated. When they do prepare a liter of solution, they often end up throwing a lot of it away or trying to save it for use over multiple days, thereby risking contamination. In addition, we know a single child will typically consume between 200 and 400 milliliters of solution per day. So why is it that 1-liter sachets are being manufactured the world over? And these are just to name a few of the challenges that we found. Now, I've had the opportunity to work on health issues on almost every continent in the world. And I'm always dumbfounded at the fact that I can find a bottle of Coca-Cola in the most remote places that I've worked. And yet, in those same places, we have children dying from preventable diseases because they can't get access to simple medicines. So we started by asking ourselves that exact question. What is it about Coca-Cola that gets it to the ends of the earth? And how can we do the same thing with essential public health commodities? What resulted was the amazing journey that my colleagues Simon and Jane Barry and I have been on over the past 3 years, what we have called Cola Life. Now, the film we're about to watch does a great job of walking you through our model and some of the early stages of our work. So in a Star Wars-like fashion, what I'd like to do is present the sequel before you watch the prequel and just kind of give you a sense of where we are today. So first, taking a human-centered design approach, working with our end users, we redefined the concept of a diarrhea treatment kit with the creation of the Kitiamoya, or Kit of Life. This is an attractive, affordable product that contains quality life-saving medicines and takes the science of delivery right down to the user level. The kit co-packages the globally recommended treatment of ORS and zinc. And given the problems we were seeing with the typical 1-liter ORS sachets, we worked with a local pharmaceutical company to manufacture mini sachets of ORS, each making up 200 milliliters of solution, which is actually in Africa first. The zinc is pediatric formulated and comes in a blister pack of 10 tablets. It includes a small bar of hand soap to tie in the message of prevention, so it's linking prevention and treatment. And it's also, it contains an instructional pamphlet which doubles as the branding for the product, so it can be changed depending on context in different countries, etc. Pivotally, the kit packaging itself becomes a measuring device for the ORS, a mixing device, a drinking device, and it can be reused later for other purposes. Not to mention that it was originally designed to fit into the empty spaces between crated bottles of Coke, to make it easier for retailers to carry back to their communities. Now, the kit and our model more generally has captured the world's imagination. And over the past year, we've been honored to receive a number of prestigious awards, including the Design Museum's Product Design of the Year, the top award at the DuPont Packaging Awards, a research grant from Grand Challenges Canada, Rising Stars in Global Health Program, and others. We were also recently invited to the UN General Assembly in New York as part of a high-level Every Woman, Every Child event, and featured as one of 10 breakthrough innovations that have the potential to save lives now. Now, it's not every day that something with the word diarrhea in it gets this much attention, so we're pretty excited about that. So we had already created an attractive, desirable, and aspirational product, just like Coca-Cola. And so, continuing to build on similar principles, the next element of our intervention involved the establishment of a value chain for this diarrhea treatment kit. Specifically, we used existing networks, including Coca-Cola wholesalers and small, private, independent, community-level retailers, to get the Kitiamoya to the customer at that community level, allowing for profits to be made at each step along that value chain. In a value chain, value flows back from the customer as the product is pulled to the customer, as opposed to being pushed, which is the case with most public health supply chain systems currently. Finally, our intervention included a health promotion strategy, which had various activities and approaches associated with it, including a cadre of promoters running workshops at the community level, training and paraskilling of our retailers, working in collaboration with health centers, posters, testimonials from mothers, radio spots, and more. So, what did we achieve? Our trial ran for 1 year, and I've just recently finished analyzing our preliminary findings, some of which I'm very happy to share with you today. And this is actually one of the first times I'm doing it. This is the second time I'm doing it. So it's exciting. So over the course of the 12-month trial, retailers serving remote rural communities in our 2 intervention districts bought nearly 25,000 kits. And as I mentioned earlier, at baseline, less than 1% of children with diarrhea were given the globally recommended combination therapy of ORS and zinc. At endline, of those children with diarrhea in the 2 weeks preceding our survey, 45% coverage is what we were able to achieve. I told you earlier that on average, caregivers were traveling over 7 kilometers to access ORS and rarely zinc. At endline, caregivers using the Kitiamoya only traveled an average of about 2 kilometers to access these medicines at their local shop. In terms of proper utilization, we know that only about 60% of caregivers using the 1-liter sachets prepared the ORS correctly. However, of those using the Kitiamoya, 93% prepared the ORS in the right concentration. We also found that the perception of ORS as an effective medicine for the management of diarrhea increased in our intervention districts from 79 to 92% of caregivers. Across our intervention districts, 95% of our Kitiamoya retailers said that they plan to continue selling the product. And finally, we found that only 33% of caregivers gave zinc for the full 10-day course, limiting its potential impact. So there's still more work to be done. Now, before we move to the film, I thought I'd summarize and close off by sharing my top 10 personal reflections on social innovation. I know that was kind of the theme of today's topic, and I know a lot of you have an interest in that area. So I did these at 3 o'clock in the morning, so don't blame me if they're not quite right. So I said Rohit's top 10 non-static reflections on social innovations, because these are kind of constantly evolving. So number 1, become the expert on your topic and try and understand your problem inside out. To do this, talk to the experts in your field. And then, once you've spoken with all of them and learned as much as you can from them, apply it and take it a step further with your own work. Also, don't forget to explore the macro and micro elements of the problem that you're trying to address. To understand the challenges to effective diarrhea treatment, for example, we took a health systems perspective to understand the big picture around the problem. Now, don't worry about trying to take all of this in. But the main thing to say is that in designing our intervention, we looked at a number of critical junctures between market forces, innovation, and resources, between resources and service delivery, between service delivery and better health outcomes. And how all of those system elements interact with individuals, households, and communities. Now, I've built my expertise in global health delivery and implementation science. And what so often doesn't happen is to focus on the details of implementation, where you blow out that bottom panel, that bottom gray panel there. And that's actually closely linked to my next reflection. And to introduce that reflection, I want to share a video from my most recent trip to the field with you. Now, this is from rural Zambia, and we had just pulled our truck up to one of the village retail shops that we're working with, and a group of kids that were playing nearby, they came running up to the side of the truck, and for what seemed like the first time ever, they saw their reflections in the door, in the side of the truck. So take a look. Reflections. I sometimes like to narrate my own videos. Now, I love this video because for me, it's a constant reminder of the vastly different contexts in which we work. Context is key, and you always have to remember your end user and keep them in mind. More importantly, you should work with your end user. We cannot assume. We cannot depend purely on what we've read in the literature. There will always be a level of local adaptation that is required, and that will come with its own necessary specifications. At Cola Life, we did a lot of formative research before designing Kitiamoya and our intervention more generally. You have to immerse yourself in the reality of how, who, where, what you are trying to address. Now, with something like diarrhea, you probably don't want to, immerse yourself too much. But you get my drift. Recognize the gaps, this is number 3. recognize the gaps in your knowledge and expertise, and develop the right partnerships to fill those gaps. You have to surround yourself with the right team. With Cola Life, one of our major achievements was the establishment of a truly global and multi-sectoral partnership. Global health partnerships are energizing and transforming the international health landscape. At Cola Life, we're only a core team of 3, yet we've convened the necessary players, what we call an unlikely alliance, to make our model a reality. Closely linked to this concept is something called integrated innovation, what Grand Challenges Canada defines as the coordinated application of scientific, technological, social, and business innovation to develop solutions to complex challenges. And this approach highlights the powerful synergies that can be realized by aligning these different forms of innovation. And it recognizes that scientific and technological innovations have a greater chance of going to scale and achieving global impact and sustainability if they're developed from the outset with appropriate social and business innovations. It's this kind of multi-pronged approach that can be facilitated by working across sectors. Number 4, there are no organizations, there are only people. Remember that it's all about effective interpersonal relationships. Now, I raise this point because I know that sometimes bringing an idea to fruition can seem like a daunting task. And for us, what seemed like some of the most daunting steps in our journey, getting a pharmaceutical company to manufacture a new-sized ORS sachet, getting a regulatory authority to approve a new product, or securing additional funding from a donor, it just boiled down to individuals. Know your partners, establish good relationships, and reassure them that you know what you're talking about. Be that expert. Oh, crap, I wasn't supposed to go to this yet. Now, I wanted my last reflection to be really inspirational so you could leave feeling motivated. And so I was going to go with this poster, Never Give Up. This is something I had on my wall throughout my undergrad here at Waterloo. And it's empowering and positive. But in this case, it's not true. Not entirely, anyways. I think far more accurate is this quote from F. Scott Fitzgerald. Number 5, strength shows not only in the ability to persist, but the ability to start over. You're going to have to know when to change it up and go in a different direction. Innovation is a dynamic process and it requires constant evolution. Don't be afraid of change. Our goal is to save lives, and so if our data is telling us that we can improve our model and potentially achieve greater impact by changing what we originally thought was going to be the key innovation, well, then we have to act on that. And that's what we're currently doing. While we hypothesized that the kits fitting into the empty spaces was going to be a key enabler to improve access, our research showed that only 4% of retailers actually used that piggybacking method. In fact, they were buying the kits in far greater quantities than the Coke crates would allow. And so they would just buy a box in bulk of kits and they would put that on the back of their bikes and take it back to their communities. And so we're currently in the process of developing new formats that actually allow us to enhance the key features, manufacture it 100% locally, and reduce the costs. That said, the original format will also be maintained in certain contexts and continues to serve as a strong metaphor and symbol for what we're doing. And with that, I think I'll zip it up. I have other reflections, but you can come and talk to me about those afterwards. Thank you all so much for allowing me to share my story. I'm looking forward to chatting at the reception after. Thank you so much to Greenhouse and AHS. It's an amazing family to be a part of, so it's an honor. I'd like to acknowledge our donors, which you always have to do. I'll let the documentary then explain the rest. So thank you.